Hello and welcome, everyone. I am Norman Aquino, joining you from Manila. It is a great pleasure to help bring to you this masterclass lecture tonight. This lecture series is envisioned to foster learning and interaction among the members of the Asia-Pacific Glaucoma Society and the global glaucoma community. It is a vital component of the educational thrust of the society, delivered in a format that is appropriate for the current times. As you can see, the Asia-Pacific Glaucoma Society has spearheaded and continued to actively participate in various educational fora despite the limitations imposed by the current situation. The very dynamic educational thrust of the society, plus all the other perks that you see here, definitely give great value to being a member of the society. If you are not a member yet, I strongly encourage you to be one. Scanning the QR code is all you need to do. For this session, you will be able to ask questions throughout. I will get to read them and relay them to our speaker and the audience during the live Q&A after the talk has ended. The title of tonight's talk for our third masterclass is The Approach to Exfoliation Syndrome and Exfoliation Glaucoma. Our esteemed speaker is Professor Lingam Vijaya, a distinguished senior consultant at the Sankara Netralaya in Chennai, India. She is a revered teacher, clinician, and prolific researcher. She is a member of the Board of Governors of the World Glaucoma Association and a member of the Executive Board of the Asia-Pacific Glaucoma Society. She is also the chair of the World Glaucoma Association Global Outreach Program. Truly, she is worthy to deliver the third masterclass lecture for the APGS. It is therefore a great honor for me to introduce and give to you Professor Lingam Vijaya.
Hello, everyone. At the outset, I would like to thank Asia Pacific Glaucoma Society for this kind invitation. I'll be talking to you an approach to exfoliation syndrome and exfoliation glaucoma under this masterclass series. So what is exfoliation? Exfoliation is also known as the pseudo-exfoliation. Both terms are accepted widely and people use it commonly all over the world. It is an age-related multifactorial progressive disorder and that produces extracellular material that results in white fibrillar deposits in majority of the parts of the body. Initially, it was thought to be a disease of the eye since it is easily seen with the slit lamp by microscopy. Later on, people realized these deposits are also seen in blood vessels, skin, gallbladder, kidneys, lungs, heart, and meninges. In view of these non-ocular deposits, it causes progressive elastotic degeneration that results in cerebrovascular disease, low-grade inflammation, elevated homocysteine in the body. It is found to be a common identifiable cause for the primary open-angle glaucoma, was first described in Finland in 1917 by Lindbergh. Since it is a common cause for primary open-angle glaucoma, treatment will be similar to open-angle glaucoma. However, it has worse prognosis due to higher and excessive fluctuation of intraocular pressure. In view of this, the protocols we follow in the management and follow-up of open-angle glaucoma may not be suitable for eyes with exfoliation with open-angle glaucoma. It definitely requires closer follow-up and aggressive treatment to minimize the visual loss due to glaucoma in presence of exfoliation. If you look at the epidemiology of exfoliation, the prevalence varies greatly depending upon the geographical location from 0.2 to 27%. Initially, it was thought to be highest in Scandinavian countries and Greece. With the more information coming out from the population-based studies from elsewhere in the world, such as India, China, Sri Lanka, Japan, and Iran, now we believe that it is seen worldwide. If you carefully look for it, you will definitely see exfoliation in any part of the world. What are the risk factors? There are many risk factors. The most important risk factor being increasing age. With the age, the prevalence of the disease increases. Increasing distance from equator has been attributed to be a risk factor for exfoliation. This latitude effect is mainly because of the low ambient light and more exposure of the sun rays because of the reflection from the snow and the water when we move away from the equator. And this makes individuals susceptible for exfoliation. Of course, more exposure to sun anywhere in the world can be a risk factor for exfoliation. We found that a rural environment is a significant risk factor for exfoliation in our prevalence-based studies in the population in our Chennai glaucoma study. So there was a significant difference between rural and urban population in terms of prevalence of the exfoliation. And ruralites definitely had higher prevalence of exfoliation. This possibly may be due to because the people who live in the rural areas are mainly the field workers. They work in the fields and they're at a higher risk for the exposure to the sun rays and exfoliation. Of course, ultraviolet rays is an important risk factor for exfoliation. Generally, it starts as a unilateral disease. With the time, it becomes bilateral. And around 30% of eyes with exfoliation syndrome will develop glaucoma with the time. The important risk factor being increased IOP. There is a limited information about the incidence of the exfoliation syndrome. And I'm fortunate enough to be associated with the Chennai eye disease incidence study, where we looked at the incidence of eye diseases 6 years following the prevalence study. So I'm sharing some information about the incidence of exfoliation from the Chennai eye disease incidence study here. In our prevalence study, we found the exfoliation being the second most common cause for glaucoma in our population. I'm using the term pseudo-exfoliation in my next few slides because that was the time we used when we talked about exfoliation in our population-based studies. If you look at the incidence of pseudo-exfoliation in our population, again, there was a marked difference between the rural and urban population. The rural population was almost 3 times higher incidence of exfoliation in comparison to the urban population. We found open angle glaucoma, angle closure, and the ocular hypertensives in the people with exfoliation. Again, age is an increasing risk factor. With the increase in the age, there was increase in the incidence of the pseudoexfoliation. We found an interesting feature that will have an impact on the management of the glaucoma with the pseudoexfoliation. We found people with pseudoexfoliation had very thin corneas and low BMI, suggesting that possibly the intraocular pressure can be tricky in this group of individuals. The associated risk factors we found were older age, rural residents, illiteracy. Illiteracy, possibly again, people who are illiterate are likely to be outdoor workers in comparison to the literates. and of course, pseudophakia and nuclear cataract. Pseudophakia and nuclear cataract association is mainly due to the fact that pseudoexfoliation is likely to have higher prevalence and incidence of cataract also. Interestingly, we found the progression of the pseudoexfoliation, that is, all the pseudoexfoliation patients who were diagnosed at the baseline in the prevalence study, when we re-examined them after 6 years, we found almost 15% unilateral cases have converted into bilateral cases, and 6% of people with the pseudoexfoliation have developed glaucoma. All had ocular hypertension at baseline. And we also found the incidence of cataract surgery was significantly higher, suggesting eyes with pseudoexfoliation association with cataract is very high. We also found some information about the mortality. Mortality rates were significantly higher in those with the pseudoexfoliation at baseline than for the rest of the study population. This trend was seen both in the rural and urban population. Even after adjusting for the age and gender, the mortality rates were significantly higher in eyes with pseudoexfoliation than without pseudoexfoliation. This possibly may be due to the fact that the pseudoexfoliation material gets deposited elsewhere in the body also, and it possibly makes this individual more susceptible for some of the systemic diseases, which I will be talking about it later. Coming to the pathogenesis of the exfoliation, again, it is multifactorial, and in an imbalance between matrix metalloproteases and their endogenous inhibitors, increased oxidative stress, and altered cellular stress response have been proposed as the pathogenic mechanisms for exfoliation syndrome. A gene-environment interaction has also been postulated, and lysyl oxidase like 1 is an important enzyme for increasing the tensile strength of the collagen and elastin. Single nucleotide polymorphism of the LOXL1 gene are associated with the exfoliation syndrome and plays a potential role in the pathogenesis. Genome-wide association studies have revealed non-LOXL1 gene loci, which are significantly associated with the increased risk of exfoliation syndrome, such as CACNA1A. Coming to the mechanism of exfoliation glaucoma, glaucoma can manifest with various ways, commonest being the ocular hypertension and open-angle glaucoma. The cause for ocular hypertension and open-angle glaucoma here is mainly because of the obstruction to the outflow channels. So the exfoliation material, pigments, and protein tends to get accumulated in the outflow channels and blocks and results in raised intraocular pressure. With the time, these deposits will lead into degenerative changes in the trabecular meshwork and results in permanent raise in the intraocular pressure that in turn will lead into glaucoma. This size also causes IOP spikes, mainly because of the melanin showers. I will talk about it when I talk about the clinical picture. The second method for glaucoma is angle closure disease. In view of the deposits of the exfoliation material constantly in the eye in different parts of the anterior segment, it results in zonulopathy due to deposits on the zonules that leads into unstable lens iris diaphragm, shift of the lens iris diaphragm anteriorly, resulting in angle closure disease. These eyes are prone to develop vascular occlusions, so there is a possibility one may develop neovascular glaucoma. Coming to the clinical signs, the early clinical signs to remember are, it is unilateral to start with. We don't know the reason, but usually literature suggests 50% will become bilateral in 15 years. Interestingly, even though you see exfoliation in one eye, the conjunctival biopsy of the unaffected eye, if you examine under microscopy, you can see presence of exfoliation material, suggesting it is a bilateral disease, but there will be significant asymmetry between the two eyes. Coming to the diagnosis, the best way to diagnose exfoliation is doing a good slit lamp by microscopy. So look for it first at the pupillary margin. So one will see the lot of material being deposited at the pupillary margin. It will be also associated with the loss of the pupillary ruff with atrophic patches that will give transillumination defects. Because of the deposits of the material in the pupillary muscles, it will result in poor mydriasis because the activity of the muscles will come down with the deposits. Whenever with the dilatation, these eyes will release a lot of pigment, and because from the posterior surface of the iris, that is from the pigmentary epithelium, this will result in transient rise in the intraocular pressure. One may see a minute neovascularization, the tufts of the vascular microvessels and the iris also. The second part one has to look at it will be lens. Lens has a very characteristic pattern of deposits. We call it as a target pattern, where you will see a central disc of exfoliation material, followed by the clear area and a peripheral rim, mainly underneath the iris. And so this target pattern happens because of the constant movement of the pupil that rubs off the material between the central disc and the peripheral rim, resulting in this pattern. This is best seen when after the dilatation. So there is a need to look at the eye after the dilatation. So to appropriately diagnose exfoliation, even if you miss the pupillary margin deposits, the lens surface deposits cannot be missed. Other than these two structures, exfoliation material is also seen in angle, antechamber, zonules, ciliary processes like here, and it can get deposited in the corneal endothelium. With the long term, because of the deposits, these individuals can develop guttata and droplet keratopathy. So when you do gonioscopy on eyes with exfoliation, typically you will see a heavy pigmentation of the trabecular meshwork, but usually it is patchy. Unlike in pigmentary dispersion syndrome, the pigmentation will be patchy and like a salt and pepper appearance. And Schwalbe's line can get pigmented because of the excessive pigment, resulting in Samples line. As I mentioned before, in view of the unstable lens iris diaphragm, one may see even narrow angles in presence of exfoliation. Other ocular associations are, as I mentioned, these eyes are will be associated with significant cataract. It is mainly due to the reduced ascorbic acid in exfoliation syndrome. These eyes will develop ocular ischemia. In view of that, iris ischemia with the microneovascularization can be seen on the iris. There will be chronic breakdown of the blood-aqueous barrier, so making these eyes susceptible for inflammation. The abnormal homocysteine metabolism may lead to vascular occlusions, such as branch retinal vein occlusion or central retinal vein occlusion. What happens with the exfoliation material deposits? There can be increase in the IOP, and for the reasons I have explained before. At this increased IOP, one should remember there will be increased fluctuations depending upon the material and melanin release. And also one should remember, following the dilatation, there will be IOP spike because of the melanin shower that happens with the dilatation in these individuals. Typically, it is seen 2 to 3 hours after the dilatation. In the posterior segment, these eyes are at a higher risk to develop the disc hemorrhage, and for the reasons I have explained before, one can see vascular occlusions in these individuals. Coming to the exfoliation glaucoma, and usually one will see greater field loss at diagnosis more with the exfoliation glaucoma than with the open angle glaucoma. And also these visual field loss with the exfoliation glaucoma progress faster in comparison to the open angle glaucoma. In view of the constant deposit of the exfoliation material on the zonules, it causes a loss of zonular integrity, resulting in narrow angles, subluxation, dislocation of the lens. Because of this, there will be increased complications of cataract surgery. Even if you succeed in doing the cataract surgery well, there will be issues of decentration of the IOL or decentration of the IOL with the capsular bag. The capsular contraction is significant in this size, and similarly, the posterior capsule opacification is significant in this size. Coming to the systemic diseases, the commonly seen systemic diseases are cerebrovascular diseases, transient ischemic attacks, aortic aneurysms, Alzheimer's disease, renal artery stenosis, and hearing loss. So we do have challenges in management of exfoliation syndrome because challenges are in 2 forms. Since it is an age-related disease and it is associated with glaucoma, we have to manage exfoliation glaucoma with open angle or narrow angle. Similarly, we have to manage cataract with the probable unstable zonular support. So I will briefly cover about managing the glaucoma and also managing cataract in these eyes. Does it behave differently when it comes to exfoliation glaucoma? So I already indicated, yes, it does behave differently from open angle glaucoma. What is the evidence we have to say that? So before we go into it, I would like to emphasize understanding of the disease is important in delivering the treatment. If you look at the ocular hypertension conversion to open angle glaucoma, in early manifest glaucoma trial, in 8.7 years followed, they found the conversion of OHT to glaucoma is twice in eyes with exfoliation in comparison to the eyes without exfoliation. We also found in our incident study in 6 years in eyes with pseudo exfoliation, only those with ocular hypertension converted to glaucoma, and the rate was 6%, suggesting ocular hypertension is an important risk factor for conversion to glaucoma, and the conversion is quite high. Why I'm emphasizing this point is, whenever we see eyes with exfoliation and ocular hypertension, definitely it needs treatment. We should not be following the protocols suggested for ocular hypertension without exfoliation. In other words, all eyes with ocular hypertension with exfoliation requires treatment. And the challenge we will face is setting the target pressure. From our incident study, we found these individuals are likely to have thinner corneas. So there is a risk of underestimation of the intraocular pressure. So the target IOP possibly has to be much lower than what we usually set it for the open angle glaucoma. In general, eyes with exfoliation glaucoma respond poorly to medical therapy. The ideal first line of drug will be the prostaglandin analog. Many times one may have to resort to the combination therapy. Generally, we don't recommend use of the aqueous suppressants because aqueous suppression increases the deposits of the melanin and exfoliation material in the trabecular meshwork, increasing the eyes more susceptible for raised intraocular pressure. Need for laser and surgery is very high in these eyes. What are the laser procedures we commonly do? That is the trabeculoplasty for the open angle glaucoma, laser iridotomy for narrow angle glaucoma. And the procedure of ALT and SLT is same as for open angle glaucoma. However, one should remember due to the heavy pigmented trabecular meshwork, the settings should be low in comparison to the open angle glaucoma eyes. Laser iridotomy for narrow angles is the routine technique, but one should be aware there is a possible bleeding from the iris because of the microvascular tufts one may see due to ischemia. An angle may not widen if there is anterior subluxation of the lens due to the zonulopathy. One should remember the IOP spike following the laser can be significant, so one should use alpha agonists to blunt this IOP spike routinely in these eyes. Also, one should remember in general inflammatory response is more, so they may need more topical steroids. Coming to the surgery, various surgeries have been tried, such as trabeculectomy. People also have advocated angle-based procedures to address the deposits of melanin and the exfoliation material in the angle, such as trabecular aspiration, abintenotrabeculotomy, viscocannulostomy. Very limited information is available on the tubes. And of course, management of the cataract is a real challenge in these eyes. Trabeculectomy is the most commonly done surgery, standard technique with the use of the antimetabolite. Outcomes and postoperative medications and complications are same as for open angle glaucoma. It can also be done with the cataract surgery. What is important to remember is the inflammatory response is more with the exfoliation glaucoma. There is a need for intensive treatment with the topical steroids. Angle-based surgeries are interesting because it directly addresses the mechanism for raised IOP and it clears the accumulated material. It restores the function of the natural channels, eliminates the blood-related complications of the trabeculectomy. Conjunctiva is preserved for any future surgeries. Trabecular aspiration is one such surgery. People have reported good short-term results, but they found the regresses with the time due to reaccumulation. Abintenotrabeculotomy or trabectome, where ablation of the trabecular meshwork is done, results are similar to the open angle glaucoma. There is very little data on the viscocannulostomy, deep sclerectomy, and the suture trabeculotomy. In general, angle-based surgeries are not done worldwide. Very small group of people who believe in this and do these procedures for these eyes. Very limited information available on the implants. People have used express implants in the past, and the tube implant information is very sparse. Again, inflammation is a significant risk factor, especially in the non-valved ones, and when the tube ligation gives way at the time, there can be significant inflammation. Coming to the cataract surgery, many times one may do the cataract surgery alone, or it can be combined with the glaucoma surgery. The combined surgery need depends upon the severity of the glaucoma, and most of the time it is the surgeon's choice, and this, as I mentioned, depends upon the severity of the glaucoma. What are the challenges one will face with the cataract surgery? In view of the deposits, these eyes will have corneal endotheliopathy, and that makes eyes susceptible for possible endothelial decompensation with the time. There is a need to carefully evaluate this the corneal endothelial status, specifically with the specular microscopy, document it, and take necessary precautions to protect the endothelium at the time of the surgery, such as using BSS plus and a good viscoelastic. These eyes will have poor mydriasis, so it can pose a challenge for the cataract surgery. Zonular instability results in lens subluxation, makes the surgery difficult. In view of this, there is increased risk of vitreous loss. And this eye is in general prone for inflammation, so there can be increased IOP, and this IOP spike should be taken care. With the time, these eyes can have IOL decentration and dislocation. So how do we go about it? So preoperative evaluation is extremely important. That is with a slit lamp biomicroscopy. And assess the corneal endothelial status, assess the pupillary dilatation. Both static and dynamic pupillary dilatation has to be assessed, and it should be made in, mentioned in the file, so that at the time of the surgery, surgeon will be aware how much dilatation is expected. Also, make a note of the density and the stability of the cataract for appropriate planning for the surgery. A shallow or irregular anterior chamber suggests lens displacement. Perioperatively, in view of possibility of complications, better to have good akinesia, and one should anticipate and keep special equipment such as iris hooks, CTR, maybe possibly a vitreoretinal backup, etc. I have 3 pearls to share with you to manage. The first one is the small pupil management. A good viscoelastic can help in stretching the pupil. If it's not good enough, one should use mechanical devices such as the Grishaber iris hooks or Beeler pupil dilator, or one can use a pull and push technique using the Coughlin hooks. Pearl 2 is how to manage the compromised zonules. The extent of the zonular dialysis can be localized. If it is a generalized disease, zonular instability, it may possibly will affect the entire bag. So management depends upon whether it is localized or entire bag is affected. Capsular tension rings may be useful for the localized loss, and it has a, and in general, we use the CNA rings when the instability is more than 1/4, where we have to anchor the ring with a suture and to give better stability. These rings offer dual purpose. One is intraoperative support. In the long term, it will stabilize the intraocular lens. The diameter should be larger than the capsular band and expands the capsular at the equator, buttress the weak zonules, equal distribution of the support, and recenters the back. It also offers a reduced incidence of posterior capsular opacification and capsular phimosis. Exfoliation with zonulopathy definitely requires a CTR, and there is no evidence to say all eyes with exfoliation syndrome will require CTR. In other words, we don't believe in giving a prophylactic CTR when we do the cataract surgery in eyes with the exfoliation syndrome without any subluxation of the lens. Pearl 3 is type of the IOL and placement of the IOL. Always place the IOL in bag. Generally, we place a single piece acrylic lens in the bag, and but there are people who believe in placing a 3-piece lens in the back, mainly because the 3-piece acts like a CTR. 1 to 2 clock hours annular dehiscence can be taken care. That's mainly because the PMMA haptics will support the bag. Also, in case of late displacement, fixing the IOL will be easy. For example, if you see here, the 3-piece lens is in the bag. There is definite subluxation, and you can see the entire bag has moved with a good filtering bleb. And we used mechanal suture and fixed the haptics and bringing back the lens capsular diaphragm into the pupillary area, and with a functioning bleb. We could salvage the trabeculectomy without disturbing it. And also we could bring back the lens into the pupillary area without any difficulty. Post-operative course following the cataract surgery, there is increased inflammation that's mainly because of the iris vascular leak and a compromised blood access barrier. This can cause IOP spikes. One has to carefully measure intraocular pressure and take care of it with aqueous suppressants, and needs aggressive topical steroids. With the time, in spite of all the precautions, if the capsular phimosis happens, one may have to resort to cutting the phimosis with the YAG laser. To avoid the capsular phimosis, the recommendation is to do a good size rexis. If there is a 1 or 2 clock hour dehiscence, a CTR can help in reducing such a problem. In the conclusion, I would like to say management of exfoliation is complex. One should do extensive discussion with the patient and plan meticulously the appropriate treatment after doing a good clinical examination. When we follow this, we will be able to do justice to our patients and minimize the possible complications associated with exfoliation glaucoma and exfoliation syndrome with or with glaucoma in association with the cataract. Thank you very much for your kind hearing. Thank you.
We thank Professor Vijaya Lingam for widening our understanding and consciousness of the complexity of this disease called exfoliation. I personally would like to particularly thank her for emphasizing that exfoliation is not just involving the eye, but involving other parts of the body. To us clinicians, to us ophthalmologists, that is one fact that sometimes we overlook very commonly. So thank you again, Professor, for your very comprehensive talk and coverage of exfoliation syndrome. So tonight, we will be starting our question and answer portion of this masterclass, all right? And let me read off the first question that has come up from the audience. From Sana Hamid, the question is, what are your thoughts on the association of PXF with abdominal aneurysm risk? Do you medically work up these PXF patients on initial diagnosis?
Okay, Naman, thank you very much for this opportunity and also chairing the session. And I'm not sure how common it is in your part of the world, but we do see a lot of them in our part. Mm-hmm. So coming to the question, yes, they can have systemic involvement, but we have not reached a stage that we are able to pinpoint exactly what percentage of the people will be having the systemic involvement, whether we have to subject them for the systemic evaluation. We are not doing it routinely. So at present point of time, I don't have an answer for that. Maybe with the time, probably we will be able to give an answer. But when coming to the eye, I think when they manifest with the vein occlusion, we do little more extensive investigation that includes the homocysteine levels also.
So that would mean if your patient had ocular signs of pseudoexfoliation plus a ischemia, then that's where you go into a more specific workup. All right, very good. Now, Professor, you mentioned earlier that timolol maleate or an aqueous suppressant is not a good initial choice. All right, there seems to be an irony there. The affected population is generally a population that will find prostaglandin analogs a little too difficult to sustain. So my question is, what about the option for these patients who cannot be on prostaglandin to have early surgery?
Yeah, in general, it is, I mean, you agree that whenever we suppress aqueous production, especially when there is deposits of material, both exfoliation and also pigment is likely to block the trabecular meshwork channels. It's not correct way of treating the eye. So we used to treat in the past with aqueous suppressants. Once that we got an alternative like prostaglandin analogs, which doesn't cause accumulation of the material because it doesn't suppress the aqueous, that is the first line of drug. It doesn't mean you should not use the aqueous suppressants, but it's better if you have an option to use the prostaglandins. I do agree that majority of them cannot afford the prostaglandins. You may have to go for a cheaper drug, which is again a beta blocker where aqueous suppression happens with the beta blocker.
Thank you. Thank you. What about SLT? I mean, is there a difference as far as outcomes in using SLT as an initial step as compared to a prostaglandin?
You can consider, but majority of these patients, by the time they come to us, and they will be having advanced glaucoma. If you have an ocular hypertension and trying to do early glaucoma, it is worthwhile to do the SLT and defer the advocating the medication for some more time till the pressure goes up with the SLT. So SLT is an option, definitely, like in primary open-angle glaucoma. Even with the glaucoma with the exfoliation, SLT is an option.
What about primary surgery? Is that an option too?
If the disease is very advanced, if the pressures are very high, patient is not able to use the multiple medications, the same protocols we follow in other glaucomas will automatically apply. So the only thing I just kept on emphasizing is that these eyes do progress more rapidly.
Correct.
So sometimes within 6 months, within 9 months, you see the field being progressed rapidly, the pressure has gone up. So the protocols we follow with the primary open-angle glaucoma will not apply to the eyes with the exfoliation, because they will need more frequent follow-ups than others. So in the cases where you are not able to follow up the patient so intensely with the shorter interval, if the pressures are not in good control, yes, you can consider the surgery. There's nothing prevents anyone from doing the surgery. So many of them will have the associated cataract. Very rarely you see only exfoliation glaucoma. So you may have to consider cataract also at the same time.
Now, you started to talk about cataract surgery. There is a question from Sunny Au. Does hydrophobic versus hydrophilic IOL matter in your choice of implants?
And in general, I think we all prefer the hydrophobic, and that is better lens in comparison to the hydrophilic. What do you say?
Well, I suppose our general go-to would really be our regular lens. Now, in connection, I'd like to ask, knowing that there are big potential challenges or problems because of zonular support, capsular support, what about using iris fixated implants? I mean, they are quite popular now, and properly placed, they will not be dependent on the traditional support system, and therefore the possibility of it being decentered or, put out of place might be less.
Maybe I will put it this way. If the bag is present, it is having a good support, and maybe it is worthwhile to put the lens in its natural position. If the bag is unstable, yes, you can always think of putting the iris support lens. But the only problem, even with the bag intact, with the time, the entire bag can dislocate with the IOL. Then you have to do one more surgery, fix the IOL with the bag into its position. I don't have my personal experience in using the iris support lenses. Yes, it seems to be reasonable option in this size. Whether the deposits on the iris will have an effect on the stability, I have no idea. So I don't have any personal experience with this.
What I found very interesting was your comment about using a 3-piece IOL, because in the future, with that kind of IOL, it is easier to salvage, with a special suture to bring it back to place. All right. So that is a go-to lens for you, correct?
Yes. I mean, if it is just 1 or 2 clock hours, we tend to still use the 3-piece, single piece, because it's easier and you're comfortable. And sometimes the 3-piece lens also can, depending upon the back support, inserting the 3-piece lens into the bag, if the haptics doesn't go appropriately into the bag correctly, if you want to dial too much, you can have problems. So teamwork is essential. So you should always have one of your VR colleague to call upon when you suspect the lens is not stable and the anterior chamber is very shallow. And when you do anticipate the problems, in one sitting, we can manage the problem well when you have a VR surgeon also as a backup with you.
What are the parameters that you use for you to decide whether you are going to put in a CTR or not?
I usually decide on if you are, I keep it ready always. So on the table, when you remove the nucleus, how the bag behaves is what we see. If you can visualize the extent of the lack of support, or if the bag turns crumbles, which doesn't happen in a normal situation. Once that the contents are out, then when you're doing the irrigation aspiration, you can see the entire bag trying to come into the port. So that is the time you have to slow down and insert a CTR and put the intraocular lens.
Very good.
So that many times you may not be able to assess it preoperatively. Preoperatively, you can assess based upon the anterior chamber whether you suspect any subluxation or not.
I mean, we appreciate all these tips that you are saying. But to me, what is very important is that the general ophthalmologist should be aware of the presence of pseudo-exfoliation. I mean, unfortunately, some overlook the findings that you see and proceed with planning for cataract surgery. And then while on the table, that's where they are suddenly confronted with a situation wherein they are not prepared for. They have no significant viscoelastic support available, or the presence of CTR, or they are not conscious of certain maneuvers that they will have to do because this case is a pseudo exfoliation. So I think as teachers, to future ophthalmologists, I think recognition of this condition, even before your patient lands in the OR table, is very, very important because...
Absolutely, absolutely. I think clinical examination is the key here. I think post-dilatation slit lamp examination is very, very crucial.
Correct.
And when I keep telling the residents that when you do the gonioscopy, if you see abnormal pigmentation in the angle, come back and look at the people again. So you may see exfoliation.
And if I may add, not all pupillary borders would exhibit the dandruff-like material. But when you dilate, that's when you see the traditional target lesion that you were earlier talking about. So those red flags alone should already alert the surgeon, even if it's not a glaucoma specialist, to be prepared for potential problems in the OR.
Yes, no doubt about it.
Correct, correct. All right.
Do you see often in your country?
We see it, but it is not a common condition that is, I mean, but to think that we are also in the tropics, a lot of our patients work out in the sun for long periods of time, but we don't see it that often as the regular angle closure or open angle patients. All right. All right. One last question. Now we realize that exfoliation is a systemic problem. Are you aware of any systemic medicines or treatments that they have?
I think the Singapore group is trying to look at the genetic basis, and they're looking at some of the possible drugs that can be used in future, like statins, if I remember correctly. So with the time, I think we may, with more of a genetics part coming out and looking at it, yes, we may get it in future. I think the Singapore group, if I'm not wrong, is looking at it.
That is going to be very significant work, considering the high incidence of this condition in your country, in countries like Japan, Korea, and even China. Yes. You know, considering the number of people who can be potentially affected, looking into this early diagnosis of a possibly systemic condition is very, very important. So at this point, we would like to thank you, Professor Vijaya Lingam, for tonight's masterclass. All right, we learned a lot.
Thank you for the opportunity and leading the discussion so well and lively. Thank you very much.
My pleasure.
Thank the team for the wonderful arrangements. Thank you.
Everybody, this is the third APGS or Asia Pacific Glaucoma Society Masterclass that is brought to you as a big effort by the society in terms of education of the ophthalmic community in the Asia Pacific region. And that is why I would like to enjoin people who are tuned in tonight, who are not yet members of the society, to please visit the website of the APGS to see how the society can be of help and relevance to you and your practice. With that, I would like to end this third masterclass session. Thanks to Professor Vijaya Lingam and the technical team who were responsible for bringing this to you. So everybody, good night, and please keep safe.
Thank you
very much.
Stay safe. Thank you.